DSW 2310, Dual Diagnosis, Treatment, and Assessment. Diagnosing. Terms. Dual diagnosis means a person experiences life with a developmental disability and mental illness. Concurrent disorders. Concurrent substance use and mental health disorders, an information guide. Concurrent disorders is a term for any combination of mental health and substance use problems. There is no one symptom or group of symptoms that is common to all combinations. The combinations of concurrent disorders can be divided into 5 main groups. Substance use plus mood and anxiety disorders, such as depression or panic disorder. Substance use plus severe and persistent mental health disorders, such as schizophrenia or bipolar disorder. Substance use plus personality disorders, such as borderline personality disorder or problems related to anger, impulsivity, or aggression. Substance use plus eating disorders, such as anorexia nervosa or bulimia. Other substance use plus mental health disorders, such as gambling and sexual disorders. What is comorbidity? 2 or more disorders or illnesses occurring in the same person. They can occur at the same time or one after the other. Interactions between the illnesses can worsen the course of both illnesses. Is drug addiction a mental illness? Yes. Addiction changes the brain in fundamental ways, disturbs a person's normal hierarchy of needs and desires, substituting new priorities connected with obtaining and using the drug, results in compulsive behaviors that weaken impulses, despite negative consequences. This is similar to hallmarks to other mental illnesses. Comorbidity. How common is comorbid drug addiction and other mental illnesses? Many people addicted to drugs are also diagnosed with other mental health disorders, and vice versa. For example, compared with the general population, people addicted to drugs are roughly twice as likely to suffer from mood and anxiety disorders. Comorbidity. Comorbidity. Persons with intellectual disabilities have more than one disease or illness occurring at the same time. Examples: developmental disability plus Alzheimer's plus anxiety. Developmental disability plus colitis plus self-injurious behavior. Developmental disability plus borderline personality disorder plus depression. Comorbidity makes diagnosing an individual very, very difficult. An overview of diagnosis: what it is, why we do it. Assessment: assigning value to something based on testing or evaluation, such as IQ testing. Diagnosis: identification by examination and/or analysis. Why assess and diagnose? Classification: to classify or place within a specific category. Intellectual functioning, learning disabled, autism. The risk: labeling based on your own attitudes and belief systems. Selection: choosing services for individuals based on classification. For example, residential, etc. Obtaining access to supports and services by having a diagnosis. Financial, behavioral, etc. Management: when person is under the direction and control of others, management decisions may or may not be in the best interests of the client. For example, treatment decisions. Facilitation: the utilization of assessment and diagnosis to create a quality of life. Treatment decisions are often based on management needs. The culture of developmental disabilities. Individuals with developmental disabilities come from a different culture or way of living. The commonality is how the intellectual disability influences or impacts their lives. The culture of developmental disabilities. thinking patterns, concrete thinkers, problems with generalization, comprehension difficulties, limited understanding of and information about the world, blind to inconsistencies, their reports versus the real world, egocentricity, don't understand the impact of their behavior on others, others' feelings, etc. Behaviors, avoidance, for example, discussing feelings, difficult topics, etc. Conditioned to please, for example, to be good and to comply. Numbed by negativity, seen as having bad reputation, so numb to discussing every detail of behavior, numb to meetings, etc. Communication, limited or non-existent verbal skills, concrete use of language, atypical meanings for words, limited vocabulary, higher than average rates of sensory deficits. Lifestyle, many have endured a life we cannot even begin to understand or relate to. For example, abuse, neglect, cruelty, instability, etc. Issues in symptomology. Can the symptoms for mental illness be identified with behavioral symptoms in persons with dual diagnoses? Aggression and self-injury. Aggression and self-injury. Are these behavioral equivalents to mental illness, or general indicators that there is a problem of some sort that must be investigated further? The specific impact of developmental disabilities on symptoms of mental health. Symptoms are most often expressed behaviorally rather than verbally. Aggression and self-injurious behaviors are seen as symptoms or indicators of mental illness at a higher rate than the rest of the population. Symptoms less imaginative and fanciful. For example, mania. He thinks he is God. When a person has a developmental disability, he thinks he is not, quote, retarded. Outward social manifestations may be less obvious. Others may not notice a decline because they have very few significant social roles and fewer role expectations. Impact of behavior affects fewer people, often isolated. Symptoms similar to those of children, shared characteristics of being powerless, limited verbal skills, dependency on others. Guidelines for diagnosis. Suffer from full range of psychiatric disorders. Always investigate medical factors before pursuing a psychiatric diagnosis. Symptoms expressed differently with dual diagnosis, behavioral indicators. Usually present as maladaptive behaviors, SIB and aggression. Symptoms may differ depending on person's intellectual disability. IQ does not predict diagnosis. Prognosis is not related to IQ, but personality, health, social supports. One behavior can mean different things at different times. Headbanging, pain, or depressed. More than one maladaptive behavior usually occurs at the same time, self-injurious and excessive crying. Maladaptive behaviors and psychiatric symptoms can coexist. Diagnosis is based on a pattern of symptoms occurring over time. Beware of pseudopsychosis. All behavior should be looked at in context of person's behavior. Down syndrome, talking to imaginary friend. Avoid circular reasoning to explain a symptom. Abuse leads to PTSD, aggressive when touched, easy to attribute all aggression to PTSD. Causality is complex. Mental illness can result from many sources, organic, social, psychological, etc. All change is important. If behavior is atypical and changed significantly, may be cause for consideration. Self-reporting is seriously impaired. Intellectual deficits, communication, understanding of feelings, etc. Lack of diagnostic instruments designed for persons with developmental disabilities. Clinical interview rarely diagnostic, can obtain enough significant information. The interview process. Issues to be aware of. Diagnostic overshadowing. All emotional problems attributed to disability. Emotional problems attributed to the disability. Baseline exaggeration. Increase in typical maladaptive behavior can be an indication of mental health. The onset and escalation. Acute disorder may be present as long-standing maladaptive behavior. Cognitive disintegration. Stress disrupts ability to process information, may look like bizarre behavior and psychotic-like symptoms, meltdown. Intellectual distortion. Intellectual and communication deficits, poor communication about history, life experiences, emotional states, etc. Psychosocial masking refers to concrete content and lack of imagination in symptom presentation, mistaken for diagnosis or misdiagnosis. The interview process. Issues to be aware of. Diagnostic overshadowing. All emotional problems attributed to disability. Emotional problems attributed to the disability. Baseline exaggeration. Increase in typical maladaptive behavior can be an indication of mental health. The onset and escalation. Acute disorder may be present as long-standing maladaptive behavior. Cognitive disintegration. Stress disrupts ability to process information, may look like bizarre behavior and psychotic-like symptoms, meltdown. Intellectual distortion. Intellectual and communication deficits, poor communication about history, life experiences, emotional states, etc. Psychosocial masking refers to concrete content and lack of imagination in symptom presentation, mistaken for diagnosis or misdiagnosis. Maximizing the success. The diagnostic interview. Obtain information before the interview. Ensure steps are taken to maximize the ability to communicate. Take time to establish a positive relationship. Maximize comfort. Accommodate the person's attention span. Communicate effectively. Keep an open mind. 3 important points to remember. Get to know the person. Build a rapport. People before paperwork. Adapt assessment and diagnostic process for success. Use information learned about assessment and diagnosis to assess dual diagnosis.